Thank you. Thank you for allowing me to attend and provide my opinion on this. I would like to start by telling you what my experience has been in addiction medicine and how long I have been practicing addiction medicine. I started and worked primarily as a family physician in British Columbia from 1992 to 2000. At that point, addiction treatment became a small component of the work that I was doing. And then in 2004, I devoted my practice completely to addictions and pain management. At that time, I was working as a consultant in two different detox facilities, one being the Cordova Detox and the other one being the Vancouver Detox. At that time, methadone was not permitted in the detoxes. We only worked with clonidine and other substances to control the symptoms. We were losing many individuals because of the severity of the withdrawal that they couldn't tolerate. We were then permitted to use methadone, but only on a tapering basis. But even then, I would discuss this with patients and say, if you're finding the methadone is helping you, let's stop the taper, keep you on this dose, and refer you to a methadone physician outside of detox so we can stabilize you on this dose, because methadone does have benefit and assist in treatments. I was one of the initial prescribers in this province of a drug you've heard as Suboxone, which is buprenorphine naloxone. I organized with the company at that time talks explaining to doctors how to use the product, so I am well versed in Suboxone. I was on the methadone maintenance committee, which was under the auspices of the College of Physicians and Surgeons from 2009 to 2014. And during that time, I taught other physicians who were trying to learn on how to prescribe methadone safely, because it is a drug that, if not used properly, can have fatal consequences. I also taught a course on pain, and in fact, one of the people I taught with was Dr. Reeb at that time. Starting in 2015, I branched out and started working in occupational medicine. Now, occupational medicine, I think, is really important in our discussion today, because this is for individuals who are considered to be in a position called safety sensitive. And safety sensitive is defined as if you make a mistake at work, either yourself, other individuals, or the organization can be harmed. When people think of safety sensitive individuals, their immediate response is doctors, lawyers, police officers, paramedics. That is correct. But there are people called safety sensitive who work on the docks. The people who work in the hospital as the cleaner is also considered safety sensitive, because if they go to work impaired and leave the floor wet, somebody could get hurt. So it is not only highly qualified individuals with degrees, etc., behind their name who are safety sensitive. Safety sensitive covers an entire spectrum of people. And in my opinion, and I will explain this, people who have either insurance or are considered safety sensitive are being offered a superior level of care. Okay. I want to talk today primarily about what I see in my practice. I am sitting today in Alliance Clinic prescribing methadone and Suboxone. Okay. Some of my patients have been with me since 2006, since I started. Okay, they have followed me from clinic to clinic. And I think what's really important, which we're lacking now as part of our treatment paradigm, is having a therapeutic alliance with a patient. Patients trust us, and that is really important. They trust our opinion. They listen to us. They come back. What we have seen with the use of these alternate medications, which are being referred to as safe supply, I'll refer to them as safer, although according to the BC Centre for Substance Use document, they're actually calling it risk mitigation. So they understand there is a risk with these medications. is we're losing our therapeutic alliance with our patients. We're losing the ability to educate them, to work with them. Prescribing medication is but one arm of treating addiction. Okay, we need to encourage them to do their counseling. Many of these patients, as you've heard from other presenters, have severe underlying trauma, have severe underlying mental issues, and have physical issues. And as a physician who does full service care, I have counselors in the clinic. We help them with housing. We help them with everything that is needed so that they can get onto the path of recovery. Recovery involves methadone and Suboxone. It involves recovery-oriented systems of care, which you've heard about from other individuals. But the important part for us is engaging individuals in recovery and not just giving them a medication. As part of my occupational health experience, I run 2 groups a week for healthcare professionals in recovery. These are nurses, doctors, pharmacists, physicians, dentists. All of these individuals, after completing intense treatment, not short-term treatment, but intense treatment, are then enrolled in a contingency-based program where, in order to remain at work, they need to demonstrate abstinence. Every one of the individuals in my group, and I have 40 to 50 people attending these groups, remain abstinent, remain at work, and remain committed to their recovery. So recovery and engagement in recovery does work. We have, as I've said before, school teachers or teaching assistants who are also involved in recovery, and for them it works too. So in my opinion, we're creating a class of people who've been offered a second-class form of treatment by just saying, here is palliative care, let's give you these medications with no proof that they work. I've heard the term, as I've been listening to the talks, of calling this harm reduction. In my opinion, this is not harm reduction, this is harm facilitation. We know for a fact that the medications are being diverted. We see it here. My husband, who's also an addiction physician, went into the store 2 doors down from my clinic, and a patient said to him, who's not a patient of our clinic, are you taking patients? And he said, yes. The patient said to him, well, can I get dillies? Now, dillies is a street word for Dilaudid. Dilaudid is hydromorphone. Okay. A person in active recovery or who's looking for recovery is not going to talk to me about dillies. Okay. I am worried what I see. I sit on a committee where prescription opioids are described, where there are members with lived and living experience who have said to us straight up in this committee, give me what I want. If I want fentanyl, don't give me hydromorphone. My voice is shouted down in this committee, and honestly, I feel intimidated because as soon as I stand up for recovery, I am in the minority. And we are made to feel very uncomfortable. We are being told, even by the coroner in British Columbia, that there are not enough of us who are prepared to describe these risk mitigation medications. We are not comfortable. We were trained from day one as doctors do no harm, and we see this as doing harm, and this is why we're staying away from it. Okay? We've had an opioid epidemic, and we are not prepared to go there again. Thank you.
Thank you very much for that presentation. We'll now open it up for question and answer with the members. And are there any members with a question? MLA Milliken.
Thank you, Chair. Thank you for the opportunity. Thank you, Dr. Melamed, for being here today and for presenting for us. I think it's fair to say that you've got quite an impressive amount of on-the-ground experience with regards to individuals with OUD. In your presentation, you had mentioned that you have some patients who have been with you since, I believe, essentially the start of when I think you kind of moved more devoted, your practice kind of moved over to more addictions and pain management. I'm not sure if it was 2004 or 2006. But you mentioned that you had some of the individuals who were with you, and I believe on perhaps Suboxone since that time. I understand that recovery is an ongoing journey and there's lots of factors to it. Would you say, though, then, just for the benefit of those listening, that there are scenarios that you have experienced where individuals who have OUD, opioid use disorder, who can be stable for extensive periods of time? And I get that it's not necessarily just the Suboxone. It could be also a family of other aids that might envelop that individual through their recovery journey. But would you say that there are individuals who have been on the road to recovery through the effective use of Suboxone for that significant period of time? I think that what we're looking at is somewhere in the neighborhood of 16 or 18 years.
Absolutely. The important thing to remember is that in the beginning, there was no Suboxone. Suboxone is a drug that was only introduced later, so the only arm we had in the beginning was methadone. We've had people who are on high doses of methadone who we've transitioned over to Suboxone because sometimes as they're tapering off their methadone, they have found the taper very difficult. We now have 2 more drugs in our armamentarium. We have injectable Suboxone, which also helps people wean off, or maintenance. In the injectable form, they come in once a month for an injection in their abdomen. It maintains them for the entire month. So there is the injectable. For people who choose to wean off, they still remain connected with me in many cases. I am still their family doctor. I am still talking to them about their children. I am working with them on their physical health. I saw a young woman this morning who's weaned off her methadone, but presented with awful anxiety 2 or 3 weeks ago, knowing this could be a risk for her to relapse. So we treat the anxiety. I have known her since she was in active addiction, had no contact with her children because they said to her, "Mom, we cannot handle you coming and going." She now has her 2 sons who are around. They're old enough not to live with her, but they're well connected with her. She goes to their sports games. They are doing fantastically. And she was listening to what I was going to present with today. And the people who are in recovery understand this. I'm not sure who it was. I think it was Dr. Lemke who used the word hijacking of the brain. Okay. Addiction is defined very easily by 4 C's. Okay. Craving, loss of control, use despite consequences, and a compulsion to use. We're then asking people whose brain has been hijacked to make healthy decisions for their ongoing care. So we work with these individuals, we help them through it, we taper them off. I received a call 2 weeks ago from a psychiatrist who said to me he had a complaint from a public health worker because one of my patients, while in treatment, had made the personal decision to wean himself off methadone. This individual is living on the island now. He is doing fantastically. I am in contact with him regularly. He's maintained sobriety since the summer. This public health worker wanted to put a complaint in against the treatment center because nobody should ever be taken off methadone or Suboxone, in her opinion. This is incorrect. If an individual chooses something and their recovery is stable and they have worked on all their arms, if they are attending extended, if they're going to meetings, whichever meeting they choose to do, if they're connected with a recovery community and the choice is theirs, I will help them wean off the drug. I will also offer them, as you've heard, naltrexone in an oral form in case they relapse, which can block them. Some of them take it, some choose not to take it. But the recovery does not have to always entail these drugs, and I am never not available to my patients, even when they've weaned off.
Supplemental?
Thank you for that. You've obviously got experience of working with individuals who would probably be, and I'm not sure exactly what the definition would be, but in some sort of long-term recovery state. Have you experienced in your practice with your patients situations or pressures whereby you've seen individuals who you were treating relatively effectively leaving potentially to pursue perhaps safe supply programs?
Absolutely. And when this was done to a young 18-year-old man, even before methadone and Suboxone were offered and we were used, the drug Cadian just came in, I really got upset about this because eventually he left. He was getting it downtown. He wasn't getting it from a reliable physician who he could meet with regularly and have all the supports around him. We see patients here who leave us. We watch them on their PharmaNet as their prescription review, maybe 4 or 5 doses or 4 or 5 days, or slightly longer, getting the harm reduction, the harm facilitation medication, and then they're gone. Okay, no more prescribing is happening. They will often come back here and you say to them, what happened? I don't know, doc. Okay. I had a situation many years ago where one of my patients left and was included in the injectable IOT program. And I actually put in a complaint because at that point, the patient had to have failed to be included in the IOT program, so the injectable program. And this patient had not failed. This patient had years of sobriety, was working in construction, and I took this. This case was taken to the ethics committee, and it was deemed inappropriate for this person to have been included at that time. And I still remember somebody in the committee saying, "Well, obviously, what you were doing was not meeting this patient's needs." But the person had to stop working because now he's using heroin 3 times a day. He became unstable. Some of these patients will come back to us. Some of them won't. We lose some of them permanently.
Thank you, Doctor. Next up, we have MLA Yao.
Thank you so much, Chair, and thank you, Dr. Melamed, for taking the time to speak to us today. I was just looking at your resume here, and you're a former co-owner and the current medical director of the Alliance Clinic in Surrey, BC, where they do prescribe opioid-assisted treatments.
That's where I am today as I'm talking to you.
Okay. So, again, the arguments for a safe supply is that it is a reasonable option that will save lives. I mean, from your perspective, are there other options for recovery based on the individual severity of their addiction, or are opioids the be-all and end-all to providing to helping people overcome these challenges?
For people who okay, so it's important to remember that for many people who in active opioid use disorder, so they're in active addiction, you say to them, why did you carry on using? They no longer enjoy what they're doing, but the biggest feeling that they experience is withdrawal. Withdrawal is described as one of the worst experiences. I remember saying to somebody, I was teaching somebody in the clinic here and said, withdrawal can be explained as one of the worst severe flus you've ever experienced. And the patient stopped me and said, Doctor, no, you are underestimating the severity of what we go through. So the reason they keep going back is because of the withdrawal. So it's important for us to manage the withdrawal, which is what methadone and Suboxone does. Once you've addressed that, then you have to treat the addiction. Methadone and Suboxone are just one arm of treating. For certain individuals, they don't want to be on methadone or Suboxone, they say, I want to be drug-free. That is very difficult, but we will support them and we will encourage them to use naltrexone, which is an opioid antagonist, which if they relapse will stop them from dying or suffering severe harm. But it is that withdrawal that takes them back, and the withdrawal feeds into the craving. So we understand that and we work with them on that. So besides methadone and Suboxone, which have long half-lives, which even if you miss a dose, you do not go into withdrawal, they will carry you for longer than 24 hours. So stops you from thinking about preventing that withdrawal, which is the major reason that many people in addiction keep using.
Excellent. Emily, Stefan.
Great. Thank you. Thank you for your presentation. I just want to ask two questions. First one is, why is BC pursuing safe supply policies despite what you're seeing?
Honestly, I don't know. Okay. Surely we would have seen by this point an improvement in the overdose deaths if safe supply was working. I struggle to say that word safe supply, but I will use it. The coroner keeps saying, well, there are not enough physicians providing this medication. So therefore, safe supply is not allowed to a large enough amount of the population. I think it was Dr. Humphreys or Dr. Schellenberger this morning, Michael Schellenberger, who spoke about the percentage of the population who being on these medications as palliative care. And I agree, okay, this is palliative care, but it is not working. I think what's happened is that, honestly, the government's got desperate. There is also a lot of outside pressure, okay, from organizations and from parents who've lost their children who've said, if this drug was available, our children wouldn't die. Well, wouldn't have died. That's a position. We don't know that. Okay. So I don't know why they're going on with this program regardless, and I think we'd have to try and weed that out of them.
Well, thank you for sharing that perspective. And whenever we act out of desperation, often we don't make the best decisions. One of the earlier speakers talked about the importance of social capital in helping individuals become free of addictions. And I'm just wondering, individuals who are using safe supply, can you maybe describe what their socialization is with others when they are using safe supply?
I think anybody who's involved in addiction is involved in the same socialization. All of these short-term drugs, be they fentanyl, which is so overwhelming and so powerful that, as you've heard before, hydromorphone is not going to cut it for people who are using fentanyl. You're on the street always looking for the next high. Okay. I don't know if anybody here has seen the streets of Vancouver recently. We have open drug use. It is continuing. It is on the sidewalks. It's all over. I myself am scared to go to the downtown east side on my own alone, which is something I never used to be. Socialization, yes. So you're sitting with other individuals who also actively using, but you're not able to pursue housing. We're putting people into housing, but every housing facility has, nearly all the housing facilities have supervised consumption sites in the facility. So even if you're trying to stay sober, it is very difficult. The dealers, according to my patients, live in the house as well. So you cannot even find a safe place in your own housing where you can get away from ongoing drug use. So socialization for these individuals, 90% of the time, involves socializing with other people who in addiction, who are either on their way back from the consumption site, accessing drugs. There is no outside involvement with anything else that's going on. We try and encourage that. We try and encourage individuals to reach out to sober people in the community. 12-step recovery is great. It is not all godly based. Agnostic AA has become very important, and I don't know if it's been mentioned yet, but the Cochrane studies that John Kelly did showed that involvement in therapeutic communities has greater efficacy. You cannot get better on your own. Okay. Addiction is a disease where you need a community, and a therapeutic community plus your doctor who helps you, although we play a very small role in this, plus your counselor, plus your recovery team is absolutely imperative for recovery.
Thank you, Doctor. Is there any other members with questions? Oh, Emily Milliken.
Thank you, and thank you for the opportunity to ask another question. This is a quick one, and I noticed that you've done some practice audits, et cetera, as a member of the Methadone Maintenance Committee for the College of Physicians and Surgeons of British Columbia. I'm just wondering if, through your experiences, whether you know, often what we find throughout this committee process is that the individuals or groups that are for safe supply so far it's been very tough to find individuals or groups from the medical community who are for this. And in that, then, do you know or are you aware of any College of Physicians and Surgeons that have approved this type of safe supply prescribing? And specifically, if the answer can only be for BC, then whether or not BC has.
BC has not. The College of Physicians and Surgeons of BC has taken a step back. Okay. When we asked to renew our license this year, there was a little box that said, will you be prescribing safe supply? And that was just because when our prescriptions come up, if we're not within the norm, we would be flagged. And that would mean that we'd be looked at. But this way, you won't be flagged, so you'll be doing something about it. They will just leave you alone. So the college is not saying don't do it. The college is not saying we will come down hard on you. But the college is not involved in this. They look after the public. They are stepping back from this. And this is being run by the government and by the BC Centre for Substance Use.
Excellent. Any supplemental? No. Any other members? We've got about 2 minutes and 46 seconds left. Emily, yeah.
Dr. Melamed, if you could just clarify, you made some comments about the coroner's office having a stance on this issue. Could you just clarify those comments? Because I'm not.
Yes.
I thought I heard you say that they were supportive of safe supply. Thank you.
Yeah. So the coroner is supportive of it. She's not a physician. Okay, and she is encouraging safe supply, but she's saying that in the deaths she's seeing, she's not seeing high levels of hydromorphone in the deaths. She's seeing fentanyl, but you cannot look at it that way. What she would have to do is look at the prescriptions that are being provided to those individuals and seeing if they're receiving the prescriptions and they're selling them, or whether they actually are not getting them. The other thing that's said all the time, I don't want to go over my time, is that these drugs are going to be safer for individuals who are using alone in their home, like the construction worker. That person is not going to go to their physician and say, I have an addiction, please give me hydromorphone. The shame and the stigma is going to keep them locked up in their private place and not change the situation for them. The other thing to remember is that every time somebody overdoses, there is brain damage. So for individuals who are having 7, 8, 9 requirements for naloxone, some of them 3 or 4 times a day, there is brain damage that's happening in these individuals.
Thank you, Doctor. And that does bring us to conclusion of our time with you today. We're all very thankful for your presentation and for the work that you do. And thank you for that.